I'm Sean Fix with Emergency Medical Consultants. We're a national training center for a number of organizations providing continuing education for healthcare providers, fire, EMS, and industry. This video series that you're about to look at is designed to help you prepare for a certification course. Remember that it's not designed to make you leave your required manual or not do your required pre-course exams prior to entering the course. It's also a great review just for clinical practice and relevance. So welcome to the Pediatric Advanced Life Support Review. In this section, we're going to review assessing children and how that's different than adults. And we'll review assessing respiratory, shock, cardiovascular, and other medical emergencies that are common in children as we go through this series. Remember that the concept of PALS is different than ACLS. In ACLS, we spend most of our time managing patients who are having cardiac arrest and some acute coronary syndromes. In the pediatric advanced life support, we spend most of our time recognizing respiratory distress, potential respiratory failure, and shock, and then we do spend some time on cardiac arrest, though the emphasis is not letting the child make it to cardiac arrest. And we know that most patients who we take care of that are pediatrics are not going to be in cardiac arrest. A very small number of them are. However, that's a very stressful and distressful event for most people. So when we look at the concept of the child versus the adult, I like to use what I call the fatal funnel. That is, the initial assessment is the evaluation of the child's illness or injury. What happened to cause this event? Is this medical? Is it trauma, etc.? And then we want to recognize the patient who might be compensating. So what they tell us is, as the patient starts to go into respiratory failure or shock, he or she compensates. And by compensation, we see an increase in heart rate, an increase in respiratory rate, restless, anxious patient. The problem for me is that's every child that I've ever gone in to assess as soon as I walk in the room. So we also look at increased peripheral vascular resistance, meaning are the capillary refills becoming delayed? Are the distal pulses becoming weak? Though that really starts happening as they get a little bit later into it. But if we don't recognize and manage this based on the story or the history, based on those early signs of decompensation, and based on what we have evaluated, if we miss all of that, the child then decreases his output and perfusion and ends up in what we call cardiopulmonary failure. Cardiopulmonary failure is at the bottom of our funnel right before cardiac arrest, and that's described as the child who's becoming bradycardic with slow, irregular respirations, or what we call agonal respirations. So the mechanism of cardiac arrest in children is definitely different than the mechanism of cardiac arrest in most adults. And the problem is this. When the adult has a sudden onset of ventricular fibrillation and somebody reaches them quickly and defibrillates them, we have a good chance of resuscitating them. When the child has been in the bottom of the pool for 20 minutes and has started off with this respiratory failure, and then he becomes hypoxic, and then he becomes hypercarbic, and then he becomes acidotic, and then he goes into a bradyrhythm, and then he goes into asystole, his survival rate is very poor by the time we get him out because we've done so much multi-system and organ damage. And if we look at some of the studies, in yellow, it's respiratory rest alone. So if we catch them while their heart is still beating and we can give them some oxygen and ventilate them, up 50 to 70% of them will come out of this and survive it. If we look at the cardiac arrest, so the child who's made it into cardiac arrest, specifically a slow cardiac arrest, not a sudden onset VFib, which could happen, though less likely in children, the survival rates are somewhere between 3 and 25%. The out-of-hospital cardiac arrest survival rate never goes more than 10%, and the in-hospital may be as high as 25%. But if we look at those numbers, that's still, most people who suffer cardiac arrest who are children don't survive that event. So one thing to remember as we're assessing children is when they're not happy that you're there to assess them. When the 60-year-old sees you come into the room and he's having chest pain, his anxiety level goes down a little bit. He's happy that the doctor, the nurse, the paramedic, the nurse practitioner, the PA, the EMT, whoever is there to help him or her. When the 3-year-old who's wheezing sees you come into the room, he's thinking, oh no, somebody's here to hurt me. And what do we teach children? Stranger danger. Don't talk to strangers. Now we want to get a 3-year-old who's wheezing to tell the nurse what's going on and what caused this and what happened after we've been telling him at home for the last 3 years, don't talk to strangers. So they become a little bit more difficult to assess. By making the child cry like we see here, we are really not making them better, especially if their problem is a respiratory problem. If we put a stethoscope on them or stick an IV needle in them and make them cry, we actually run the potential of making them worse. So here's what most of the studies in pediatrics tell us. They tell us that a good assessment tool for evaluating pediatrics is what we call the pediatric assessment triangle, or the general assessment triangle, which should be started from across the room. So before I walk in the room and make the child more anxious or the parents more anxious, what I want to do is I want to look at 3 things. I want to look at his general appearance, and I want to know, is he appropriately active based on his age and the environment? Does he have adequate muscle tone? Is he able to move his arms and legs? Is he able to sit up if that's age appropriate for him? And does he have an appropriate verbal response, even if it's to the mother, responding to the mother or the father or the caretaker? I want to look at his work of breathing. Is he breathing effortlessly? And I need to have somebody lift his shirt up. I want to see, is he having retractions? Is he having seesaw respirations? Is he having grunting? Just from across the room. I want to see if I hear any noises when he's breathing. Do I hear a wheeze? Do I hear any crackling? Do I hear any gurgling? And the last thing I look at is circulation. I want to know, are his extremities pale? Are they mottled? Are they blue? Does he have any obvious bleeding? Does he have a petechial rash? Does he have any red splotchy or purple splotchy areas on his body? So that's called the pediatric assessment triangle, done quickly from across the room and from further away from the child versus closer, meaning I would probably walk in and look at capillary refill on his foot before I stick a stethoscope on his chest and get him more anxious, if that's appropriate for that particular child. So during the PALS class, we talk about evaluate, identify, and intervene. And what that means is this. The evaluation, we do a quick primary survey after we do the rapid assessment triangle. So we're going to do a rapid airway, breathing, circulation, disability, and exposure, or ABCD exam. We're going to get as many vitals as we can get, and we're going to look at a pulse oximeter. By that time, in the first minute or so, we should be able to tell if this child is significantly ill or not. That is, do we need to call for help? Do we need a rapid response? Do we need to think about transferring or transporting him to a pediatric specialty facility? And obviously, during this entire time, we need to intervene. So evaluate, identify, intervene. And what that means is take care of any problems as you see them. Obviously, if the child was in cardiac arrest, we would start circulation, airway, breathing. If the child is awake, we would make sure he has patent airway, he's breathing effectively, he has adequate circulation, and then determine where he goes, if anywhere, from that point. So we said, initially evaluate this child from across the room. And when I look at this child, I look at him and see that his activity level looks good. He's able to sit up. He has good muscle tone. He doesn't look to be in any respiratory distress. And I don't see that he's mottled or pale or blue. So I'm not overly concerned that this child is in a critical state right now. The only thing I might move quickly in on this child is to put the bed rails up to keep him from falling or climbing out of bed. So general appearance, what am I looking for? Does he look good? Does he look bad? What is his mental status? Is he responding appropriately? Does he have active movement, and is he moving appropriately? Is he acting right for his age? The 2-year-old who puts his arm out and lays there while you start an IV on him should make you a little bit nervous. The 2-year-old who you have to wrestle to start an IV is more of an appropriate response. Even though we look at blood pressure cuffs and pulse oximeters and all of our monitors, rely on looking at the patient as well as looking at the monitor. That is, the patient whose saturation might be 96%, but you're looking at the patient and he's gasping and gagging and having retractions. should lead you to believe that that 97 either is not true or is not going to stay true. What we know is that pulse oximeters are about 2 minutes behind where our crashing patient is. So you might have a patient for several minutes who's deteriorating, but his saturation, if that's all you look at, still looks appropriate. So when I look at patients from across the room, I would say, what do I notice with this patient? So hopefully you recognize that he's got supraclavicular retractions in his neck area. He's mouth breathing, and he's got nasal flaring. So this is a child with a respiratory distress problem. I would want to know what the story and the history was with this as well. Was he a trauma to the chest patient? Was he having a cold and congestion patient? Did he eat bad peanuts or something like that? So remember that just like ACLS, what we say in PALS is our goal is to keep the O2 saturation between 94 and 99%, as higher oxygenation levels might give us a higher blood gas level, which can be toxic to some patients. This may not be as critical in children as adults, but we still use the same concept. So when we talk about the primary survey in children, or the primary assessment, we use an acronym A, B, C, D, and E. So let's take a look at those. The airway in most children and most patients really that we encounter will be clear, unless you work in like a vent hospital where your patients are all intubated. But for most of us in our careers, most patients have an open, clear airway who are conscious. PALS describes the second term for airway management as maintainable, meaning the patient snores or gurgles unless we do some basic maintenance, like maybe positioning them or suction them or give them an oral airway. And then they go on to describe the airway that is non-maintainable as the patient who doesn't breathe effectively on their own and needs some type of advanced device, such as a paralaryngeal airway or an intubation or even further. So when we look at breathing, we say that we evaluate the respiratory rate, and we'll talk about what normals mean in a minute. We evaluate the effort or the mechanics of breathing. What does the chest look like, which means the shirt needs to be removed. We look at lung sounds and air entry. What noises do I hear as I stand a few feet away from the child? And are there any other noises that I might hear with my stethoscope? So is he having inspiratory stridor? That sounds like that. Is he having wheezing that we hear on expiration or exhalation? Does he have crackles or rhonchi that we hear with our stethoscopes? We also look at what is the skin color and what is the pulse oximetry reading. Again, with a reminder that pulse oximetry should be a supplement, not your only thing that you're evaluating in somebody in respiratory distress. So if we look at normal breathing rates for children, we see that infants can be in the 30s to the low 50s. We see that the toddler or the 1 to 3 year old runs in the 20s to the high to mid 30s, and as they get older, those numbers will decrease. So the child who's of school age, 5 to 10 years old, 18 to 25 or 15 to 25 is the evaluation that is in the normal range for those particular patients. So as we move forward and we look at this child here, we see that respiratory distress is described as increased work of breathing. And I would think that everybody would agree, as soon as you look at this, this usually makes people open their eyes a little bit. This child is having significant respiratory distress. When we talk about respiratory failure, we either say the child is not breathing or not breathing effectively, meaning he's not being oxygenated well, or that he's not ventilating or not ventilating effectively, meaning that he is not perfusing at the lungs well. And we can measure both of those. We can measure oxygenation with our pulse oximeter, and we can measure ventilation with our CO2. So as the patient's respiratory stress increases and he's not ventilating appropriately or effectively, his CO2 will start to rise. At some point in time, his O2 will also start to drop. So remember that respiratory failure is not just somebody who has quit breathing. When we look at respiratory distress for breathing, the PALS curriculum describes respiratory distress in several ways. They say that potential respiratory failure is the increased work of breathing, where we see tachypnea, retractions, nasal flaring. We know that probable respiratory failure is the child who's starting to deteriorate. He's getting too tired to hold his head up anymore. His head is bobbing as he breathes. He's getting lethargic. He's getting tired, and he starts grunting. As he's grunting, he's trying to open up his alveoli because they're either not getting enough tidal volume and they're collapsing, or because they are covered with infiltrates like pus or pneumonia. And he's trying to open those alveoli up the same as we would do by giving him CPAP or BiPAP or PEEP. So when we look at respiratory problems in kids, we put them into 4 categories. Upper airway obstruction with the stridor noise that you heard me do earlier. Sometimes we might see drooling with those patients. We see an increased inspiratory effort on those patients. If we look at lower airway obstruction, which is going to be into the lungs, we see things like asthma or bronchiolitis. They have an increased expiratory effort with a prolonged expiratory phase. There might be coughing or wheezing, and we might have decreased air movement or decreased lung sounds all over. When we look at specific tissue disease, lung tissue disease, lower airway lung tissue disease, we see things like pneumonia, pulmonary edema. We see the child start to have crackles. These are the children who may start to grunt. We may see decreased air movement. These children become more hypoxic and are a little bit more serious. We may see inadequate breathing efforts in them as well. And then the child who has a CNS dysfunction, whether it's from a disease, whether it's from an injury to the brain, whether it's from a seizure, or whether it's from a CNS depressant medication, irregular rates, irregular patterns, inadequate effort, and they'll have periods of apnea with that. So that's for disordered control of breathing that you might see in the patient who's got some type of brain disruption or dysfunction. So when we talk about managing respirations and ventilation and breathing in patients, we look at a couple of things. We said most patients will maintain their own airway. We know that in the adults, right out of CPR, you were taught if a patient's not breathing effectively or is unresponsive and we have to open the airway, we do a head tilt, chin lift to tilt the head all the way up. If we do that in children, we know that it actually occludes the airway right out of basic CPR. So we put them in what's called the sniffing position. And the sniffing position is lifting the back of the head or the occiput as if they were sniffing a flower that you were holding in front of their face. We can give them oxygen in several ways. If they're breathing effectively on their own, but they do need oxygen for whatever reason, blow-by oxygen is effective. So we can take an O2 mask or an O2 supply tubing if the child is anxious about having oxygen put on them and put the oxygen next to their face. If the child is in significant distress or shock and he needs higher amounts of oxygen, we can put an oxygen mask on his face. And certainly nasal cannulas are used in pediatric settings for children all the time. If the child is not breathing or not breathing effectively, we know that we may need to bag valve mask them, and we bag valve mask them for respiratory arrest only at about 1 breath every 3 to 5 seconds, or 12 to 20 breaths a minute. Or if the child is in cardiac arrest and we're doing CPR, it's the same as an adult, 1 breath every 6 seconds. So if we look at positioning of the airway and the sniffing position, I've given you a couple of examples here. On the bottom right in an infant, if we elevate the infant's shoulder to make up for the fact that they have a large occiput that forces their head down when they become unconscious, elevating the shoulder like that small picture will put us in a more neutral position. In the older child or toddler children, if we elevate the neck and the occiput a little bit and put the ear in line with the shoulder, that will give them a better open airway position. Doing so in each of these unconscious patients allows us to ventilate them easier, allows them to breathe easier on their own if they're breathing on their own, and if we end up having to intubate them, makes it easier for the intubator to perform the skill of intubation. So we should consider intubation or advanced airway procedures in several patients. Any patient who's unconscious with no gag reflex and not some condition that we're going to fix right away may need to be intubated. Patients in profound shock may end up intubated, and patients who require bag valve mask for more than 1 minute may also require intubation. So that would be the patient who has respiratory arrest, respiratory depressions that's not responding to bag valve mask, tachypnea with poor tidal volumes, like that infant we looked at a little while ago who seemed to be in severe distress, or even bradycardia that does not respond to bag valve mask ventilation. So if we look at intubation of the pediatric, things to remember. Number one, if you're an intubator, this is important. Positioning is important. Having a clear airway that you can see is important, and not putting the blade in too far is important because the glottic opening for children sits much higher than the glottic opening for adults. If we're using any one of the other airways, sizing them appropriately for children becomes important. Remember, they're sized based on the patient's weight, and whether you're using a paralaryngeal airway, a laryngeal mask airway, an iGel, a King airway, a intubation tube, or a bag valve mask and oral airway, remember that at the end of the day, the goal is, are you able to make enough tidal volume to make the chest rise? That's what we're worried about. So as we look at C, circulation, we want to look at a couple of different values. We look at what is the heart rate? Is it normal and appropriate? Is there an appropriate distal perfusion? That is a capillary refill that's appropriate in the appropriate patient, and distal pulses. Um, the blood pressure we will look at, however, the blood pressure is the last thing to deteriorate in a patient who is crashing or deteriorating. So the blood pressure is the least of our concerns in a child until it becomes low. Because what that means, it's a very late sign and the child has already been decompensating for an extended period. So we're looking at end organ perfusion. What I want to know is the brain getting oxygen and blood and glucose like it's supposed to? Is the skin, and are the kidneys? So that's what we're going to look at here in these next couple of slides. So when we talk about evaluation of circulation to the brain, are they acting appropriately? Do they have an appropriate mental status? We look for a central versus a peripheral pulse. So can I feel a pulse in the carotid or the brachial, and can I also feel the same strength in the distal pulse at the radius of the arm? We look at quality of pulse, we look at skin temperature, we look at capillary refill, with a little reminder that this capillary refill is only good in a normothermic patient. Small children who become cold quickly may get mottled and have delayed capillary refill. So while we use capillary refill and we like it, remember that if the patient is excessively hot or the excessively cold patient, we're going to have an irregular reading and it's not going to be accurate for us. We'll look at blood pressure a little bit later, and as well as urine output, as we are continually evaluating those patients for circulation. So we really want to spend time evaluating the extremities, because what happens is when children decompensate, they get peripheral vasoconstriction in the arms and legs. So the arms and legs may get pale, cool, or mottled more so than the torso. We said that capillary refill is a good finding, though think about the ambient temperature and that particular patient, and we look at the strength of the distal and the peripheral pulses. So the skin color, is it normal? Is it pink? Is it pale? Is it blue? Is it mottled? So we're looking for irregularities in perfusion. This slide shows a capillary refill of 10 seconds with a normal blood pressure, and the patient doesn't survive even though his blood pressure was normal. When we look at blood pressures, here's what we want to know. This is looking at the lower fifth percentile, meaning the lowest acceptable blood pressure. And the lowest acceptable blood pressure starts at 70. So for an infant, we say the lowest acceptable blood pressure is 70. Anything below that is considered hypotensive and more critical. In the child age patient, which is up to maybe 10-ish, or puberty, we say that 70 plus twice the age is the lowest acceptable blood pressure. Generally, the normal blood pressure in that age is 80 to 90 plus twice the age. And then in children who are over puberty, we use the same settings as we do in adults. Any blood pressure below 90 is considered critical or hypotensive. When we look at heart rates in children, we see there's a great variation here. And part of the recommendation is that you have a device to evaluate that and calculate these so that you're not having to memorize all of this. So whether you have this on a chart or whether you have it on some type of resuscitation tape or card or app, the recommendation is have that to evaluate. So if you look at this, you'll see that in infants, 100 to 180 is just a normal day for them. And as we get older, 140, normal for a toddler, with up to 120 into preschool age children. So certainly we know that heart rates can be faster, and we need to keep that in mind on these patients. So when we look at heart rates in children, what we say is this: an infant is considered to be in sinus tachycardia until the heart rate goes over 220. Meaning at 220 or greater in an infant up to 1 year old, we might start thinking about SVT. A child is from 1 year old to puberty. We don't start thinking about SVT in those children until the heart rate goes over 180. So as we continue with circulation, we're looking at end organ perfusion, specifically long-term management anyway of the kidneys. So what we want to know is the patient continuing to make urine at 1 to 2 milliliters per kilogram per hour, and this will be measured throughout his or her stay in the hospital, especially a child who is or was hypoperfused or shocky. For those of you that do pre-hospital medicine, responding to a child who is just ill or sick long term and who especially looks unstable, a question might be to the parents is, hey, have you been changing as many diapers as normal, or has the child been urinating? And we're not looking about the child who's done that, who just broke his leg. We're talking about a kid who's been sick for several days or longer. A, B, C, and D. D is disability. Real simple and real quick. They took information from the trauma courses and said, how do we evaluate level of conscious and neuro, very quick bedside? And they use the acronym AVPU. A means the patient is awake. V means the patient responds to voice. P means the patient responds to pain. And U states that the patient is unresponsive. Later on, we'll look at other tools like Glasgow Coma Scale, pediatric Glasgow Coma Scale pupils, but quick bedside is A, V, P, and U. And then E is expose and examine the patient as appropriate. As I mentioned earlier, any child in respiratory distress, we should have his shirt or her shirt up and off so we can look for things like subtle signs of respiratory distress, early retractions, supraclavicular retractions, abdominal breathing, that type of stuff. Injured children need most of their clothes off in the area that's injured. And then we need to remember exposure control afterwards, which means once we've removed all their clothing, that we need to warm them up and keep them under a blanket as appropriate as well. In this section, we're going to look at shock and evaluating shock in children and how that's different than in adults. So no matter what text you read or what version you read, we say that shock is the inadequate tissue perfusion or inadequate blood flow or inadequate blood perfusion, something like that. Here's what I think is important about evaluating shock. Number one, in children, I need to know the story, whether it's the story from the family member, the story from witnesses, or the story from another caretaker. What happened to this child to cause his injury or incident right now? Did he fall off his bicycle? Did he get run over by a car? Was he underwater? Did he take some of grandma's medications? And then we want to evaluate for early signs of compensation. So that would be tachycardia, decreased perfusion to the extremities, whether it's noticing a color change in the distal extremities, weak distal pulse, or poor capillary refill. We want to look at altered mentation from restless, anxious, agitated, all the way down to unresponsive. And we want to see a discrepancy in the distal pulse versus a central pulse on these patients. Remember that blood pressure dropping in a child, like we would expect in an adult, is a very late sign. The child who drops his pressure is considered to be in hypotensive shock and is much more serious than the child who's in compensated shock, that is, has a reason to be in shock and maybe has some weak distal pulses or some pale extremities or a delayed capillary refill. So remember that hypotensive shock means that the compensation mechanisms have failed, the patient is dropping his pressure, and those children have a higher mortality rate. When we look at the types of shock in children, we see that hypovolemic shock is the most common type of shock. In the injured child, it's usually from a bleed, often in the abdomen cavity or the liver. In the small child, infant, it's usually from gastro. So that is a standard shock that we would see in all categories of patients. Distributive shock is what I call medication shock, because these shocks need medication to manage. So septic shock is a toxin in the system which causes us to third space fluid and vasodilate. That shock, obviously, along with fluids, is going to need some antibiotics to fix that problem. Anaphylactic shock, a reflex vasodilation, and third spacing of fluid, again, from an allergen, while it may require fluids, is also going to require some IM epinephrine to manage. Neurogenic shock from a spinal cord injury, while again may require some fluids, is also going to require some type of vasopressor to manage that place. The obstructive shocks, like cardiac tamponade, from trauma or non-trauma causes, tension pneumothorax, causing a lung to collapse and push on the mediastinum and the heart, or pulmonary embolism from a clot frequently in the pulmonary artery. And also cardiac arrhythmias, heart rates that are going too slow causing poor perfusion, or heart rates that are going too fast causing poor perfusion. Septic shock is different. So remember that in septic shock, those patients may have a normal cardiac output, may have normal capillary refills, and still become hypotensive before we recognize that. So those patients are a little bit difficult and different in evaluating them. So when we look at septic shock, early signs might be fever. However, remember that children who get febrile sometimes get cold, especially small children, instead of hot to touch. They have tachycardia and tachypnea, which we may expect. However, we may misdiagnose that as something else. When we look at their blood work, we may see that they have an increase in white blood cells or a decrease in white blood cells. They may have immature cells called band cells. So again, they don't present as normal as what an adult who's septic might present. Early management, oxygen, airway, ventilation, vascular access, fluids, and if we don't know the cause of the infection or the patient is immunocompromised, certainly antibiotics, and the new recommendation is early antibiotics should be administered early on in patients who are candidates. We may even need to use vasoactive infusions in critical care areas. So let's take a look at managing shock in children after we've recognized the condition. So the first thing we say is maintain circulation, airway, and breathing like we do in all patients. Maintain body temperature. What that means is the child is hot and febrile, remove their clothes to cool them down. If the child is cool, like in traumatic shock, put some blankets on them to warm them up. Stop any bleeding, even minimal bleeding, because bleeding is cumulative in the child. Administer high flow oxygen. So in the shock patient, different than in the ACLS patient, we don't get as concerned about oxygen toxicity and giving too much oxygen. If the patient's in shock, they should be given high flow oxygen. Obtain vascular access rapidly. Whatever you can do quickly to get an IV if the child's in shock, whether it's a peripheral IV or an intraosseous site. If the child is showing signs of shock, even if he has a low blood pressure but a reason to be in shock, we should be giving him fluid boluses of 20 milliliters per kilogram, infused rapidly in less than 20 minutes, provided he's not in cardiogenic shock where we might have some cardiac problems. 20 milliliters per kilogram is the standard. You might see some literature that says if they have a cardiac insufficiency, give a little bit less than that. But the general rule is 20 milliliters per kilogram of an isotonic crystalloid like saline. If we're using blood or packed red blood cells, we may give half of that for each infusion. So when we look at intraosseous infusion in kids, we might be able to push that amount in with a small syringe if the child is not overly large, meaning we're not having to push in 600 milliliters at a time. We might be able to use an infusion pump, or we might be able to use some other device or technique designed for that, depending on where you happen to work. Here is a demonstration of intraosseous infusions being performed by a company who developed a device, and this is live with no anesthesia.
All right, Scotty.
I'd rate that a 2.
What?
Yeah, that's definitely a 2.
All right, now we're going to aspirate.
I can't feel you're aspirating.
Isn't that beautiful? Oh, it's coming out so easy, the blood is.
And I can tell you that the insertion was like next to nothing.
Really?
Absolutely next to nothing.
Wow. It was fast. It went in
It went
really,
really
easy.
fast.
It was shockingly easy.
I've had IVs that hurt worse. I mean,
15 per 6 seconds times 10 is a minute, so it's 100. That's 150 per minute.
yeah, it's a totally zero. It's totally flat. It's good and stable. I feel absolutely nothing around it.
Okay. Okay, we're going to use a technique of holding the leg, pulling gently upward while we twist clockwise.
I felt nothing. Not a damn thing.
You see, people are worried about how bad it's going to leak and bleed after you take it out.
Not,
IVs do worse than that.
oh, yeah.
15 gauge IV, can you imagine?
Remember earlier on I talked about the fatal funnel, and the very last portion of the fatal funnel is cardiopulmonary failure. This is a child who's about to suffer cardiac arrest. So they have bradycardia, poor perfusion, decreased consciousness, and the management of them is pretty simple. Oxygenate and ventilate. So the first treatment for bradycardia in children is oxygenation and ventilation. We do that for 30 seconds to a minute. If they don't get better and the heart rate doesn't come up to an acceptable range, at least above 60, though we'd like it a little bit higher, we begin CPR. So unlike adults, children who have a heart rate below 60 that does not get better when you oxygenate them and ventilate them will get CPR for approximately a minute. At this point in time, the team should be gathering, consider intubation, and if a minute after the CPR, the child still has a heart rate below 60, we're going to start administering our first med as if we were working cardiac arrest, and that's going to be epinephrine. So again, a little bit different than the adult. The epinephrine dosing should be based on some type of a pre-calculated system, as should all of our other medications and equipment usage for children. So whether you're using the Broslow tape, the hand-Tevi system, the PD wheel, or some other calculation system, you shouldn't be trying to do this in your head as you're managing a pediatric emergency. When we look at trauma in patients, a couple of things to keep in mind. Airway and breathing problems are more common in trauma in children than are circulatory problems. We still use the standard approach, except when we look at airway, we try not to manipulate the neck too much and we maintain spinal motion stabilization. When we look at breathing, we pay special attention to the chest and we look for things like a potential pneumothorax or a tension pneumothorax by looking at chest rise, equal movement on each side, lung sounds, jugular venous ascension, respirations that are getting worse. When we talk about circulation, we talk about controlling all bleeding. We control and manage any of these life-threatening events as we move on. Let's look at a couple of common emergencies in pediatrics. Fever. One of the common things that we see children for in the hospital setting is fever. And what they say is if the child's temperature is greater than 100.4, or if the child is less than 8 weeks old and there's no source of the fever, we should be considering an antibiotic. And the recommendation is that it's done within 1 hour of the recognition of the child. If the child is just febrile, remove their clothing. Consider possibly ibuprofen or acetaminophen at the physician's discretion. Seizures are common in children who end up febrile. They are also common for other reasons, but the febrile seizure is the one that we're going to talk about initially. So generally they're self-limiting, they look really bad. The child who has a seizure from a fever is going to have a very upset parent with them. And when we get concerned is when it becomes a status seizure. That is seizure activity that lasts without stop for more than 5 minutes. 2 or more seizures without the patient waking up in between, or at least regaining consciousness. Or repeated seizures greater than 30 minutes total time. Those are seizures that we consider emergencies and they need to be managed more aggressively than just a febrile seizure that lasts for a couple minutes and then stops. So the general seizure management is this. Protect the patient from injury. lay them on their side to maintain their airway, place some oxygen on them or near them, and then think about what medication might be used in your setting to control this. Base your dose off of a pre-calculated system, so you're not trying to do math in the middle of the resuscitation or the middle of the management of this emergency. So you might use lorazepam, you might use midazolam, you might use Dilantin or one of those medications. Whatever medication is appropriate with your physician. Remember that post-medication and post-seizure, the child has the potential to have the disordered control of breathing and may have periods of apnea following that, so he or she should be monitored closely for that. Another common condition in children that we don't think about is hypoglycemia. We think about it if the child has a history of diabetes, but remember that children who are stressed or distressed physically from shock or respiratory compromise can burn up their glucose stores. They don't have as good a glycogen store as adults do, and they may actually become hypoglycemic just like a diabetic with no diabetic history. So that post-arrest, post-drowning, post-trauma patient at some point in time should have his glucose evaluated, and if appropriate, glucose administered if the sugar is less than 50 or 40 depending on your patient. We might use 25% dextrose, we might use 10% dextrose, and in some settings, in the older patients, you might see an order for 50% dextrose as well. Allergic reactions in children, remember that anaphylaxis is life-threatening. What they say is it's true anaphylaxis is if two systems are involved, whether it's respiratory and neuro, or respiratory and skin, or GI. When we think about it the most is the patient who has signs of shock, signs of respiratory distress, and maybe swelling to the face. These patients need immediate treatment and literally can die from this in short order. So when we look at managing true anaphylaxis, what we say is maintain their airway and give them high flow oxygen, give them epinephrine IM at 0.01 milligrams per kilogram. Again, dosed based on a pre-calculated system. Be familiar with your system and familiar with the IM dosing, because we don't use that as often based on our resuscitation systems. They might need some diphenhydramine, they might need solumedrol, they might get an NH2 blocker, all depending on their condition and what your physician is requesting at that time, or what your protocol is for managing that case. They may need a fluid bolus. We can lose liters of fluid in patients who are third spacing fluid during anaphylaxis. So that's the review of assessing children for respiratory failure, shock, and deterioration, along with a couple of common emergencies in kids. Thanks for listening.